Good evening, everybody. I am Dr. Tariq Katamish from Cairo University. I'm happy to moderate this very interesting interactive corneal discussion session in El Qasimi Ophthalmology International Conference. We'll be having tonight very distinguished speakers. We'll be having 5 presentations. We'll start by Dr. Hejra Saeed. She will be talking about severe ocular surface disease and bilateral microbial keratitis in a patient with Stevens-Johnson syndrome. Then we'll be having Dr. Farhad Hafzi. He will be speaking about cross-linking in ultra-thin corneas. And then we'll be having Dr. Amal Al-Waraikat. She will be speaking about a peculiar type of lens that resulted in corneal decompensation managed by DMEC. Also, we'll be having the Professor Dr. George Aliou from Spain speaking about DMEC in especially difficult cases, how to do it successfully. Lastly, I will be presenting a case of a partially collapsing transparent big bubble, a unique case. It's my pleasure to introduce our speakers today. Dr. Hejra Saeed, consultant ophthalmologist, Massachusetts Eye and Ear, Boston, Director Cornea Fellowship, Harvard Medical School, USA. Dr. Farhadi Hafzi, Professor of Ophthalmology, University of Geneva, Switzerland, Clinical Professor of Ophthalmology, Keck School of Medicine, Los Angeles. And I am honored also to introduce Dr. Amal Waraikat, Cornea and Refractive Surgery Senior Specialist, Jordanian Royal Medical Services in Jordan. And I am honored also to introduce the great Professor, Dr. George Aliou, the Professor and Chairman of Ophthalmology, University of Alicante, Spain, and the Medical Director of the Vision Cooperation. And lastly, myself, I am Professor of Ophthalmology in Cairo University. So may I introduce the first speaker? I don't know if Dr.
Tarek, if you can start, Doctora, she is not available until now. She didn't join. So if you can go to the next speaker.
Next is Farhadi Hafzi. You have a pre-recorded talk for him or no?
Yes, sir.
He is going to be a pre-recorded. So please,
okay,
the team.
So we're having now a pre-recorded presentation of Dr. Farhadi Hafzi about cross-linking in ultra-thin corneas. Please, the presentation, please.
In a cornea of more than 400 microns of stroma. But what about these cases where you are facing a very thin cornea, either localized or over larger areas that is much thinner than 400? How have we cross-linked these corneas in the past? Well, it all started with our own publication back in 2009 when our group in Zurich brought swelling of the cornea with hypoosmolaric solution. This was the first attempt to perform cross-linking in very thin corneas. A few years later, Susan Jacob from India proposed contact lens assisted cross-linking. Now, if you ask me today whether I use any of these methods to perform CXL in thin corneas, my answer is no. I don't perform contact lens assisted cross-linking. I don't even perform the method we established ourselves. Let me show you why. Because both of them have major disadvantages. If you swell the cornea, then the biomechanical improvement is quite good. Wollensak has published on this back in 2019. The big problem is the whole amount of swelling is rather unpredictable. Some corneas swell a lot, others almost do not swell. So you never know what you expect when you start the procedure, and that's not a good feeling for a surgeon. The second method, contact lens assisted cross-linking, sounds so logical. If the cornea is too thin, you increase thickness by a contact lens, but you lose 30% of efficacy. We have shown this back in 2015. Wollensak has confirmed this in another publication 2 years ago. You lose a lot of efficacy because even the best contact lens is a relative barrier to oxygen. So neither of them works really well. But taken together, both of these techniques had one thing in common. We somehow tried to increase the thickness of the cornea because our technology said we need 400. So in other words, until now, we adapted our cornea to the cross-linking protocol, to the technology. From now on, we will do something more logical. We will adapt not the cornea to the protocol, we will adapt the protocol to the cornea. So if the cornea is thin, we need a different protocol. And this is what we did. So these are the steps in the sub-400 protocols. First, we had to develop an algorithm, how to adapt the total energy so we don't harm the endothelium. It's all about not harming the endothelium and to have a demarcation line that is deep, but not too deep. And so we developed an algorithm and created a nomogram and published this back 4 years ago. But this was not enough. This is just theory. So the next question was, we have to validate this clinically. And so we started the clinical study. And what we did is these 4 steps. So standardize the method. You remove the epithelium, you apply the riboflavin, and then you measure thickness after 10 minutes of riboflavin application. And this value is the thinnest point of the cornea. And based on this value, you adapt the fluence. And how do you do this? We published the entire clinical study in the January edition of the 2021 American Journal of Ophthalmology journal. And here you will find a nomogram. So if you have a certain thickness after 10 minutes of riboflavin and epi-off, let's say 280 micron, then you know that you need these many minutes at 3 milliwatts to reach the right demarcation line depth. And as I said, this was a clinical validation which took us almost 3 years in a prospective monocentric interventional study. And the success rate was remarkably high. It was 89%. I didn't expect 89%, but these are the numbers. I would have been happy with 75 or 80%. And we also see a nice decrease in Kmax readings. Now, having this nomogram and this published table, you can perform this method with any machine, but you have to look up and calculate the right amount of time. For the convenience, in the latest technology that I helped develop, the slit lamp based cross-linking, the whole nomogram is already in the machine. So all you need to do is to open up the machine, enter the thickness that you need, and the machine will calculate the rest for you. Now 2 more things. There is an Indian calculator on the internet that says it also has a nomogram. It has different values from our sub-400, and there is no clinical validation of the study. So it's a pure theoretical nomogram. And the second protocol that came up in the last 2 years comes from my friend Cosimo Mazzotta from Italy. And he has the M protocol. Where is the difference to sub-400? The M protocol is simply a collection of everything that has been published until now and which protocol goes how deep. So he has a collection of continuous light, of pulsed light, of low fluence, of high fluence, of 3 milliwatts, of 15 milliwatts, and so on. And he put together every depth of treatment so you can choose between the different protocols. This here is an entirely newly developed nomogram where you just need one intensity and then you adapt the fluence. That's the main difference. The last question I get again and again is, well, why do you perform cross-linking in ultra-thin corneas? The patients don't see well. They should be on a transplantation list. This was true up to a few years ago, but let me just show you this extreme case. This is a patient who has had a central scar, a remaining stroma of 108 microns, so a little more than 100, a huge compensation of the epithelium of 150 micron, Kmax readings that were in the range of 85 diopters. The vision with glasses could not even be measured, and the vision with scleral lenses, an astonishing 20/30. And so if you can improve vision to that means, then cross-linking ultra-thin corneas is a means for us to preserve the cornea and to delay the moment or by which you need corneal transplantation. So in conclusion, the future in ultra-thin corneas is individualized cross-linking. Treatments down to 200 microns of stroma are possible. And in fact, we have just published 2 months ago the very first case of keratoglobus treatment. So an overall thin cornea of a little more than 220 micron that was able to be stabilized. So this also works in new indications that have never been cross-linked before. And you can perform this treatment using all cross-linking technology or use the CI device with the integrated protocol. Thank you for your attention.
Thank you, Dr. Farhadi. We'd like to have you with us tonight, but unfortunately, we don't have you. So may I ask any of the panelists, Dr. George or Dr. Amal, if they have any comment on Dr. Farhadi talk? Hello?
Yeah, this was a very interesting talk, as always, and we always learn from Dr. Hafizi about there is nothing that is solid in the collagen cross-linking. Always, the more we get data, the more we modify our techniques. So yeah, that was a very interesting presentation.
But I have a point Dr. Farhadi have mentioned in his last point in his talk, that what is the value of actually of cross-linking such a very thin cornea, which is functionally very bad and it will need a transplant, but he showed some benefits from this technique. So I think for the time we have to move to the next presentation. We'll be having now Dr. Amal Al-Waraikat. She will be speaking about a peculiar lens that resulted in a corneal decompensation and managed by DMEC. Please, Dr. Amal.
Thank you, Dr. Tariq, for your nice presentation and introduction, and thank you for including me in this prestigious meeting. So today I'm going to present an interesting case that I've never seen before. So this is a patient who is a 52-year-old male patient that he was referred from a nearby country to evaluate his bullous keratopathy in his right eye. He was complaining of glare and blurry vision in the right eye and also some symptoms in the left eye. So he had a history of myopia and a history of high myopia. He underwent a bilateral phakic IOL implantation in Moscow in 1988. And he was at the age of 20 at that time. So when I looked at his eye, this was something that I've never seen before. I've never seen a lens that looks like this. And I was talking to one of my colleagues in the US, whom I did training with him in Boston, Dr. Naveen Rao. And at the same night, he was submitting a video to the askers about how did he deal with such a case. So this patient presented with counting vision close in his right eye. This is the right eye, which is the one, the worst eye. And he had a cataract behind this lens that was encircling the pupil. So when I looked back, it turned out to be the most primitive form, or the first form of the ICL, the implantable Collamer lenses. So this was developed by Dr. Fedorov, and this patient had the surgery done in 1988. So this was the first generation of those lenses. It has that shape and that platform. And then there was the second generation of the Fedorov phakic IOL, the Sputnik lens that has this shape. And the surgeries were done, to a huge number of patients who underwent the procedure and on rotating tables. So each surgeon would do a part of the surgery. And all those cases were monitored and by Dr. Fedorov. So my patient, my plan was to explant the phakic IOL and do phaco, and then, trying to deal with the cornea. So this is the procedure. The view was very hazy, but we had to take this lens out. I removed the epithelium, and I tried to take the lens in the same way I would do for the ICL, the type that we know and we deal with now. So I was able to rotate the lens, bring it into the anterior chamber, and cut the lens into two halves, almost 90, down to the 90%. And then I was able to pull the lens outside the eye. And then we underwent the regular phaco procedure. So I'll skip this part for the purposes of the time. So this was the patient eye at the end of the surgery. So those types of lenses were discontinued due to high risk of complications, endothelial cell loss, and late onset uveitis. This patient has the surgery done at the age of 20, and when he presented 30 years down the road, and actually was, so we saw this complication in his eye, and then the risk of cataract formation. The potential mechanisms of the endothelial cell loss in those patients could be an intraoperative, or also an endothelium lens edge touch, a chronic low-grade inflammation, and metabolic disturbances. The cataract formation, the mechanism of cataract formation could be due to surgical trauma, due to the lens, crystalline lens touch with the IOL, and then the chronic low-grade inflammation. So we are looking at the ideal phakic IOL that we are seeing and dealing with today. We should have an easy insertion, removal, and exchange that does not require a large wound, adequate fixation, but with a thin AP diameter and not touching the adjacent ocular tissue. It should have a large functional optic and negative and a positive spherocylindrical powers. So we ended doing DMEC for this patient, and this was one of my cases. So we had to remove the epithelium again, and I did prepare the DMEC tissue in this patient. I used the scuba technique and to prepare the DMEC tissue. This is, a conventional surgery in this patient. So we scraped the endothelium, and sorry, I'll go back. And so the endothelium was scored and removed. This is a 2-minute video. You can stop me anytime, Dr. Tariq, if we are running out of time. So we are removing the diseased endothelium. Taking the viscoelastic out and decompressing the anterior chamber. And I have the DMEC graft that is marked, and then closure of the main incision and manipulation of the graft. I use SF6 in those cases. It does not look as nice as Fuchs patients. The view is a little bit hazy, and in our area, most of the irises are dark. So sometimes you need to restain the graft to be able to see it inside the eye. So it is a little bit tricky. Then at the end of the surgery, we insert the gas, and we have done a peripheral iridotomy. This is the F mark. I do it manually. I prepare my own tissues. And toward the end of the surgery, we can see the F mark in the proper orientation and position. So this is the patient eye at the end of the surgery. And thank you so much.
Thank you, Dr. Amal, for this nice presentation. Just want to ask you about the first case you have shown to us, the Fedorov lens you have explanted. Did you continue the case as the MIC, or you do it in another session?
Actually, you know, I had enough stress to deal with an unknown lens in the beginning, so I did it as a staged surgery. I dealt with the lens, and I did not know, you know, how the things will go. Would I be able to take the lens and deal with the cataract? So I usually do it on whether endothelial keratoplasty, whether a DSEK or edemic. I like to not to do a triple procedure most of the time, so that, you know, I will concentrate on the cornea or on the cataract.
And from this experience with very old models of phakic IOL, what is the best phakic IOL for you nowadays? What you are using now? You are using the ICL, or you are using the iris color lens? In your opinion, you have mentioned a lot of parameters for the ideal phakic IOL. So what do you recommend nowadays use as a phakic IOL?
Yeah, so I think we don't know down the road, but now we use the Vizian ICL, and we see a very nice results over the last, you know, since we started doing it. I'm not sure how long, but it looks safe. We are following the patients with specular microscopy every year, checking the IOP, and the things look good, but we don't know down the road, like this patient had a complication 30 years after the lens that was placed. Usually I get away from anything that is attached to the uveal tissue. I like the ICL for the extreme cases, and I see if the patient is selected well, the AP, the diameter, the AC depth, all the parameters are okay, then I think it's a safe and a good procedure and a reversible procedure at the same time. So
yes, I agree with you that the ICL have proved a great efficiency. And a last question for you, since you have mentioned that you in your area in Jordan, as in our country, also in Egypt, who have a bad cases with bad corneas. So what is the percentage of your endothelial keratoplasty procedure? You are doing more DSEKs or more DMEKs according to your bad cases of bad visualization?
Yeah, so I started doing DSEK surgery after I was done with my fellowship in the US in 2015. I did the first case in Jordan. That's how the endothelial keratoplasty was introduced to Jordan. I do most of the time the ultra thin DSEK. So I bring a pre-cut tissue with 50 to 100 micron. So I do the ultra thin, and I find that the ultra thin DSEK is very comparable to the DMEK. DMEK is the best. But you know, it depends. So I don't get an imported DMEK tissue. If I have a local donation and the age is suitable for preparation for DMEK, I go for DMEK. But most of my cases are ultra thin DSEK, nano thin DSEK, and I think they are very comparable to the DMEK.
I agree with you, and thank you very much for this presentation. And we will continue speaking about DMEK with Professor George Aliou. May I introduce my Professor George Aliou. He will speak about DMEK in especially difficult cases, how to do it successfully. Dr. George, please.
Well, thank you very much. And let me open my presentation. And I'm sure that you will, just excuse me. For any reason, I cannot open. I think that the previous speaker has to close the presentation just to continue.
Dr. Amal, did you stop your sharing or not yet? Dr. Amal, are you with us?
Yes, Dr. Tariq, I stopped sharing my screen.
Stop the sharing? She stopped sharing her screen, Dr. George, actually.
Yeah.
Sir, please open your presentation. Your screen is shared.
Wait a minute, because I have a problem. Could you take to the next speaker, because my presentation is not running.
Okay, I am the next speaker. If you can,
Yeah, I need to exit and to enter again. So please,
okay, so I will proceed
make the
myself.
next speaker. Yeah.
Okay, I will proceed. Okay. So I will share my screen now. Is it clear now? Excuse me. My
Yes,
screen is
Dr.
apparently-
Tariq. Yeah, we see
I
the
will
screen.
Okay, I will speak about what I call it a partially collapsing transparent big bubble, a unique case. Why I am calling it a unique case? Because the bubble is transparent, but we have to ask ourselves, what is the usual color of a big bubble, type 1? This is a very important question. The second, it is a collapsing big bubble. Is collapse of the big bubble is a common? And thirdly, it is partially collapsing. And if we have collapse of big bubble, is it usually complete or partial? We have to answer all these three questions to know how unique is this big bubble. So usually the big bubble type 1 has a white color, as you see from these 4 examples. This is a rule that you have a white color because of the stromal emphysema, and most of the big bubbles have this characteristic white color, as you see, because of the air in the stroma. So the rule is that you have a white big bubble. The exception is you have a transparent big bubble like this. When you inject air very deep, you will be having, you see, the bubble is transparent. The edge only is white. Another example, the bubble is almost transparent. The third example, the bubble also here is transparent, as you see. And the fourth example, the bubble is transparent because I'm usually injecting very deep in the stroma near to my target, descending membrane target, so the bubble forms immediately without any emphysema. So the being transparent is the exception. Collapse of the big bubble is a very rare phenomena. What I mean by collapse, when the bubble forms, when you are going out by the cannula, the air escapes with you. Usually this collapse is complete. As you see here, when you have the big bubble, and then when you are going out, you will find the bubble will collapse, as you see. And this was the cause of this collapse. There is a leaking track. Another example of complete collapse of big bubble, you see this bubble, and then when you are going out, it comes with you. I will do it in a slow motion. Again, you see this big bubble, you see, and when you are going out, it will collapse with you. You see, it collapses, complete collapse. It never partially collapse. And then if you do the small bubble test, you will find that the small bubble test is negative. So this is the collapsed big bubble. So I will come now to my case, is the unique case of partially collapsing, not complete, transparent, not white big bubble. So as I have mentioned, I usually do a very deep terrifination. Then I mark the deepest part, make the first small nick by insulin needle, then by a rounded spatula, I do a deep groove in the deep stroma, and then going by the blunt cannula and injecting air. Since I'm injecting very deep, I will be having, look now, I will be having a transparent big bubble. You see this transparent big bubble, and then it will collapse now. You see, when you are going out, the bubble collapsed, but it is partial collapse. As you see now, I will make paracentesis. I will try to inject again to rebuild the bubble again. You see, this is the remaining of the bubble. Injecting again, it will expand. You see, it expanded like here. And then when I'm going out, I will find the bubble will collapse, and it will be, this is the big bubble. You see the border of this. This is the first time I think that someone can see the big bubble. You see, this is the big bubble partially collapsed. So while pressing with a sponge, you find the edge of the bubble. This is a bubble in the cornea, not bubble in the anterior chamber. So to solve this situation, I will go injecting viscoelastic material. This viscoelastic material, look the wave of the viscoelastic material here. It expands and would let the big bubble expands to the end of the terfination. So big bubble now is well maintained. I will continue the operation by the usual way, making stromal dissection. And after making stromal dissection, I will open the roof of the bubble. It is filled of viscoelastic material now. And I have opened the roof now and continue by cutting the stroma flaps by blunt tip scissors. And then I will continue by the right and left corneal scissors. But before that, I have to remove the viscoelastic material thoroughly. And I have to make blunt dissection of the remaining area, which is not very well dissected by air. I make sure that the edge of the bubble have reached the terrifying edge, and then continue the operation as usual by using the right and left corneal scissors, removing the remaining stroma. As you see, thorough washing of the viscoelastic material again. And then I will put just some dryness and putting the graft and suturing, as you will see now. Just put the graft and make the 8 marks. So until the video finish, this is a peculiar case of number 1, transparent big bubble, not white. Number 2, collapsing big bubble. Number 3, it is partially collapsed, not completely collapsed. And it is the first time, I think, that can someone see the big bubble itself inside the cornea, because we usually don't see the big bubble because it is completely white. Thank you for your kind attention, and may I take the chance to announce for the 4th Myome annual conference. It will be next October in Dubai. This will be in-person meeting. So we'd like to see you all in person next October in Dubai. And thank you for your kind attention. Anyone has any comment on my presentation before we start with Professor Dr. George Aliou?
Well, one question only, Katamis. How do you match the donor with the recipient? Same size, or because you have manual trephination, right? You don't use femto.
Yes.
So the size in keratoconus, because this is the indication, right?
Yes. Most of the cases are, of course, keratoconus patients. So if the case is a moderate keratoconus, I make a disparity of just a 1/4 millimeter, the donor being larger than the recipient. And in severe advanced cases, I may use the same size of terfination to flatten the cone.
I completely agree. Completely agree. Thank you.
So I think this is the last but not the least presentation. We are honored to have Professor George Aliou. He will be speaking now on DMEC in especially difficult cases, how to do it successfully. Yes, please, Dr. Professor.
Well, thank you very much, and I apologize for the inconvenience, but I'm not in my computer, and that was the problem. My talk will be now about DMEC in special complex and difficult cases. Definitely, DMEC is today the gold standard treatment for corneal endothelial diseases. We have a partial or parallel, almost completely abandoned this site for different reasons. First, it is clear that we have ultra-thin dissect, but the randomized clinical trials really demonstrate that ultra-thin dissect is worse than DMEC. It's clearly worse. Not only that, but the results compare in other randomized study confirm these outcomes. And not only that, but with nano dissect, which is the nano-thin dissect, the thinnest dissect that you can do, has been demonstrated again to still present significantly faster recovery in DMEC and less aberrated cornea in terms of dissect. So our position is we don't do dissect at all, almost only in one situation that I will tell you, and even in difficult cases, we prefer to do DMEC. So when we consider DMEC in all cases, especially in difficult ones, for instance, a vehicle with no compartmentalization, we have a normal iris where the artisan lens is to be implanted, rotopupillar we do DMEC. We have a normal iris but an iridia, a lens like the Reaper or Morcher to be implanted, we do DMEC. And this is the only one situation which we do DMEC, in which we don't plan to implant any type of intraocular lens because we don't do, obviously, DMEC in cases of aphakia. We have, when we have the significant anterior chamber ictus prolapse, then we do DMEC, tapping the anterior chamber shallowing, and the bridge is back in most of the cases of we do at the same time a posterior vitrectomy on a limited basis. In pseudophakic IULs, we use the DMEC, and either we exchange it by a rotopupillar artisan, but in two different stages. We prefer, especially in dark irises, not to perform the surgery in the same step because this dark iris brings a lot of fibrin because of the surgical trauma and are not controllable. Not only that, many times you have synechiae, and it's better to have some posterior segment reconstruction in these cases. In doing that, we have in cases in which the anterior chamber lens is well placed, and we have we can do the DMEC on top of the previous lens. You can see here one of our videos in which we are doing leaving the anterior chamber lens in place, and we are doing the DMEC without any particular problem. The case did very well, as you would see immediately. This is the case of the surgery, so we respected the anterior chamber. The surgery was mostly less traumatic and was very much effective. You can see here how was the aspect, and the patient recovered, as you see here in the screen, a very good visual outcome. Then in posterior stromal opacities that affect the posterior stroma, we do femtodilec. What is femtodilec? We have deep lamellar tissue, stroma, excision with the disease endothelium, and then we do DMEC. Look, this most interesting case that we have published with a corneal cirrhosis. That's what we did. We did a hybrid deep lamellar endothelial keratoplasty that it would be similar to the DSEC, but we implant instead of a DSEC lenticle a DMEC. The loss of tissue is not relevant because it can be 70 microns or 80 microns, and the results, and even refractive results, are very good. So our indication is bullous keratopathy with posterior stromal scar or any posterior corneal scar, as you would see now immediately. You can see here this case how we ended with a very good result. And look, you can see that even that we don't need to transplant the posterior stroma, but only the DMEC in cases that we excise the posterior stroma opacity, and we use a femtosecond laser for the purpose. This is a case in which we had deep interstitial opacities that is published in Cornea 2019, and we did the same. We did a dissection of the deep stroma with the assisted with the femtosecond, and we cleared completely the cornea, and then we implant a DMEC lenticle. As you see here, that the DMEC is properly attached, and even the tissue that we have excised is not relevant in terms of the volume of the cornea. Here you can see this case. It was performed by Jorge Barrio. See how we are delimiting with the femtosecond the case. We have calculated with the OCT scan of the interior of the cornea how deep we should go, and here you see how we are going at 400 microns from the epithelial surface, dissecting the corneal surface. Finally, we enter the anterior chamber, and we are dissecting, as you will see immediately, this lenticle, which is quite easy to eliminate because the femtosecond really behaves like in a normal LASIK flap. It's a posterior LASIK flap, let's say. And in doing that, you see how we can do that with an inverted Sinskey hook. It detaches perfectly, and so we are eliminating this opacity in 8 millimeters diameter without any particular problem, and implanted a DMEC lenticle that is attached in the usual form, not creating any particular problem in the surgery. The possibility of the case, you will see immediately, was very good, and this is the way in which we are dissecting and making femtodilec, which in our hands has saved many cases from penetrating keratoplasty, doing a very good job, getting a very good quality of cornea, and definitely improving the vision of the patients to normal levels. Not only that, the refractive outcome is not different than DMEC, something that is quite surprising because we suspected that these cases should end in more hyperopia, something that is not the case. Here we are now making the peripheral iridotomy inferiorly, were making a place suture in order to prevent the extrusion of the lenticle. And finally, we are injecting the lenticle that is created in the way that we create usually. We do our lenticles ourselves. It's the best way to create the tissue. It's much cheaper, and you control all the variables. It takes some time. The learning curve has to be made, but you see that we can obtain the DMEC lenticle without any particular problem. And basically, once that we do an 8.25 diameter lenticle, we are injecting this slightly larger than the one that we did in the DMEC. We do a triangular orientation mark in order to know that the lenticle is really properly placed and not upside down in the anterior chamber. And with this, we are loading and finally injecting. And then by tapping the cornea, we are expanding the DMEC lenticle, and the surgery is over. Here is the case. As you see, that the frontal leg did very, very well, and this posterior opacity did excellent. Finally, we are doing also cases in failed endothelial keratoplasty with anterior chamber lens. The anterior chamber lenses, phakic lenses, are tricky, and many times these patients are young and should not be explanted because they end in an anechonia, and to perform a chase is with a lot of potential problems for the retina in this space. So what we do, as far as the clearance of the anterior chamber is enough, even with the supported lenses, we do the surgery, and as you see, the surgery is successful. We have also a DMEC over previous failed DMEC. Sometimes you have this problem, and the problem is that the section of the DMEC lenticle, the previous one, is traumatic, and many times you leave a kind of trauma in the posterior stromal surface. In doing the DMEC injection over the previous one, we have found no problems. Look here how we have this double DMEC that seems to be unremarkable. The visual outcome is excellent. Look here, the two DMECs, how they are showing in the RCT scan, and particularly they are this technique is quite applicable as well in cases of rejected penetrating grafts, in which again you have sometimes a difficult time to dissect the endothelium because it is very firmly attached to the cornea. So what we do in this case is we do the DMEC on top of the previous endothelium, which is diseased and obviously almost absent, and we do it successfully. We have a system of follow-up in a series of cases that has been published. We have a very good outcome in these cases, and in this one that you can see here in the image, this was a penetrating graft in a Axial-Rieger syndrome, very complex, with glaucoma and with a valve, and we did the injection, the implantation of the DMEC successfully in this patient. That was really a tremendous challenge. Here's our series of cases that we published about this implantation of DMEC on top of the previous and the failed endothelium successfully. And the only pitfall that we see is that we have a larger number or percentage of republic. In glaucoma filtering devices, we have also the possibility of performing DMEC, something that has been denied by some authors. This is not true. We can have an anterior chamber loss, but basically what you get is a very controlled situation in which you get the patient very properly treated, and with a problem that is more frequent, we have had no problems in performing even with this technique. In young phakic guys, you have the crystalline lens, and we try to use air instead of SF6 in order to prevent the induction of cataract, something that we have never seen, but always you have to take care about making a very small pupil with acetylcholine, and to reduce the pupil size makes these patients to do well with the DMEC as well. In DMEC for aphakia, is it possible? We don't do that, but I have brought to you this video of Manny Proal, who makes this type of a bridge with a tenofovir in order to prevent the lenticle to go beyond the pupil. And with this prevention and with this Hancock, this doctor is making DMEC even in these cases. We are planning to do that, but not yet in our hands has been performed. And what about performing DMEC in a previous implanted lens with an ICL? This is a patient that had the ICL implanted and developed this type of a problem. You can observe here that the patient was with a crystalline lens that was normal, was 34 years old, and was implanted with a Kellman lens. This Kellman lens is a tricky lens as well, and it's not necessary to expand the lens to make the DMEC. The results at the 6 months follow-up was very good, and you can see here that we did, in this case, we took the lens, we explanted the Kellman lens, we implanted an ICL, and on top of the ICL, we had the surgery. Let me go again through that. This is the case of the patient that was borderline to be decompensated with the angle-supported Kielman lens, the dual lens. We expanded the lens, became decompensated, and we had an ICL. Well, how to follow? We did the DMEC on top of the previous, on the already implanted ICL with no problems. This is remarkable because it said that you can end with opacities, and we had no problems with this. You can see here how is how was the cornea, how was it left, and finally we had no problem. So the makeover ICL is feasible, has not been reported so far. Is at this moment submitted for publication. And what is true is that probably the presence of the ICL between the lens and the anterior chamber might have a protected even on the lens. Natural lens of the eye, so that, as I mentioned to you, even in young people, we have done that with very good results and without complications. So in summary, DMEC is a feasible technique in especially difficult and complex cases. DMEC is feasible even in funky guys with an ICL placed, even with an ICL. DMEC is the best surgical technique for endothelial failure, corneal stroma is transparent. DMEC is a better option of so what is impossible is not impossible, it's really possible as far as you denominate the technique. This is our online course on refractive corneal lens surgery. We include all these techniques in corneal surgery in this online course of 500 hours of teaching activities, all in English, that I offer to young ophthalmologists as part of their education with a university degree. I thank you very much for the kind invitation. I feel sorry not to be in Dubai. I'll sit at a lot and to enjoy the friendship of all my colleagues. Thank you very much. And I'm open to any question you find it convenient.
Thank you very much, Professor Aliou, for this comprehensive presentation with a very difficult cases. And I'm happy that the MEC can go for such difficult cases, but I have a couple of questions of you. We have only limited time for discussion because we have Dr. Hejra joined us. We still have another presentation. So my first question, are you unfolding the MEC graft over the anterior chamber IOL? You are not feeling from the damage of the BMMA from the contacting with the DMEC endothelial cells?
Tarek, as far as you have a good clearance, the answer is no. You have a good clearance, you have 2.8, 3 millimeters from the third surface of the lens, PMMA lens most of the times, and the posterior corneal surface. You can play the game with a bubble, you inject, and you can, the lenticle is supported by the PMMA lens. And we had a successful case. I showed to you a couple of them now, and as you see, we have successful outcomes. Other chance that you have is to expand the lens if you don't have an adequate lens, or you don't feel that the case is going to work, and then to implant an ICL which is thinner. That makes room for the DMEC as the post-op. But definitely what we try is to avoid lens surgery in young patients with this complication, because we don't want to have a healthy cornea with a retinal detachment that the patient with 34, 35 years of age is very prone to have this complication. So this is a way to escape from another problem. But my answer to you is, at the beginning, we were doubtful about the success. Finally, we did cases. They have been successful. So far, we always do the DMEC with the anterior chamber lens in place as far as we have the adequate clearance of the anterior chamber. Thank you.
And do you have any experience of doing endothelium in or pull through DMEC in such difficult cases?
No, at that level, no. As I mentioned to you, we do DMEC over previous DMEC or DMEC over previous failed graft because of rejection successfully. And these are the cases that we were much more in doubt of what to do, because we thought that it might be that the first endothelium and the cement could make an interference with the new graft becoming opaque. The case is that they only in one case the opacity was there, probably because the opacity was already underestimated by us in the subendothelial stroma. And this case we did a femtodilect and was successful as well. Femtodilect is a great technique, let me tell you.
Thank you, Professor Aliou. Unfortunately, we have to finish this discussion because we have another presentation. May I introduce Professor Dr. Thank you, Professor. May I introduce Dr. Hejra Saeed. She will be presenting a case of severe ocular surface disease and bilateral microbial keratitis in a patient with Stevens-Johnson syndrome. Dr. Hejra, please.
Thank you, everyone. I'm sorry for the delay. My son was sick a little earlier and I had to delay my presentation.
Nice to have you.
Thank you very much. Let me just pull up my presentation here. Okay, so I'm going to view a case report here of a case of bilateral microbial keratitis in a patient with Stevens-Johnson syndrome. Given the time allotted for these presentations, I'm going to go through some of the more major points, and if there are any questions, we can always discuss them in the discussion portion. I have no financial disclosures. So I'm going to start off with the chief complaint that this 37-year-old man came in with, and he had burning and redness of both eyes. That was his presenting complaint. On the day of presentation, he said that he had burning and redness, tearing and blurry vision of both eyes the previous night. The symptoms were getting worse in the morning. He then woke up with a pruritic rash on his arms and face, and that progressed to his feet and chest within 1 day. He also felt feverish, he had diffuse muscle aches, and he also later developed a sore throat, but denied any diarrhea, vomiting, cough, or rhinorrhea. His past medical history is as listed here, of note colon adenocarcinoma, which I will discuss in a little bit, which is relevant in this case later. And when he first presented to us, his vision was 20/25 -2 in the right eye, 20/30 -2 in the left eye. The rest of the exam up until the anterior segment, quite normal. He did have some conjunctival injection of both eyes and then some SPK, some dry surface on both eyes as well. Nothing particularly concerning for any severe disease. His vision also is relatively okay. The next day, his vision was relatively stable, but his rash started to get worse and started involving his mouth. So patients with SJS can often present with ocular symptoms as their first symptom. And as you may know, SJS, which is Stevens-Johnson syndrome, can be very severe and life-threatening. It has a mortality rate of up to 35%. So it's very important that we are able to recognize this disease in conjunction with the ocular symptoms. So with the worsening rash and worsening rash involving the mouth, we had him admitted to the general hospital. He had initially presented to us at the eye hospital. And at that hospital, the dermatology team had seen him and gotten a skin biopsy. Skin biopsies usually take a couple days to come back, so we still did not have any definitive diagnosis on this patient. On the next day, his vision was stable, but he was having a little bit more difficulty opening his eyes. On the conjunctiva, he was having confluent palpebral lid margin epithelial defects, more extensive bulbar conjunctiva involvement, and staining that was approaching the limbus of the conjunctiva in both eyes. So at this point, we decided to place amniotic membrane graft and start him on our typical regimen for patients with possible Stevens-Johnson syndrome, including moxifloxacin, predforte, fluorometholone. The valacyclovir and IV solumedrol were started by the primary team since we did not have a definitive diagnosis yet. The skin biopsy then came back on day 5. Which showed that the entire epidermis had detached from the dermis, and this finding was compatible with Stevens-Johnson syndrome. All the other labs that were done in the previous days in order to rule out other diagnoses all came back negative. He was hospitalized for quite some time, as often these patients are, and his vision continued to deteriorate slowly over time, as you can see here. He then, at the 1-month mark, started developing eyelid margin keratinization of the upper and lower lid. It was evolving the central eyelid, and that is important because keratinization can start rubbing on the ocular surface and cause severe damage to the cornea, as we'll see later. Because of the damage that he started having on his cornea, we placed a Procera and then referred him for a mucous membrane graft, which involves taking a piece of the labial mucosa from the lips or the cheeks and placing them in the area of the keratinization on the eyelid to allow a new smooth surface onto the surface of the eye. But because of the active disease that he was having from his Stevens-Johnson syndrome and the oral ulceration, mucosal ulcerations that he was having, he actually could not have the MMG done. And so because of that, we actually just placed contact lenses on the surface of his eye and later referred him for something called prosthetic replacement of the ocular surface ecosystem, which are essentially specialized scleral lenses to protect the ocular surface from the lid. 2 months later, he still had persistent epithelial defects of both eyes and eyelid margin keratinization. Because of these non-healing epithelial defects, we actually got cultures, even though he did not have a frank infiltrate. And he was referred for the PROS lenses I had mentioned. And interestingly, on his cultures, he did have a bug that grew, which was Enterococcus in the right eye, and that is definitely not something that is commensal or that you would expect on cultures. His left eye, even though that also had a persistent epithelial defect, did not have any bacteria or organisms growing on cultures. But given that he had epithelial defect in both eyes and positive cultures in one eye, fortified antibiotics of vancomycin and vancomycin was started in both eyes hourly. Unfortunately, despite aggressive treatment, he was continuing to worsen. He had worsening pain. The ulcers now were progressing. He started to develop an infiltrate, and he started to develop progressive thinning with concern for keratolysis, and his vision dramatically changed and went to light perception in both eyes. This is a picture of his eye when he presented after the infiltrate started to form. Very dramatic presentation. His cornea was clear. His vision was in the 20/60 to 20/80 range. Suddenly developed this ring infiltrate appearance, and vision dropped to light perception. So in this patient with SJS, with bilateral non-healing epithelial defects and cultures in the right eye, growing enterococcus with worsening pain and keratolysis, so these are some of the questions that we had. What are the next steps in diagnosis and management of this patient? Should we admit this patient? Is there a role for systemic steroids for the keratolysis that he's having? What about the systemic or the role for systemic antibiotics? And I don't think there's necessarily one right answer for these questions in this very unique case. But because of the worsening disease that he was having in the setting of a positive culture and with topical fortified antibiotics around the clock, we got a confocal on him. And with confocal imaging, you can sometimes detect other microbial diseases that you otherwise cannot detect on culture. And acanthamoeba is something that is notoriously very difficult to grow in culture. And when we got this confocal, you can see these very characteristic double-walled cysts concerning for acanthamoeba in the right and left eyes. Now, if we go back and look at this photo, this is probably a pretty classic photo for acanthamoeba with this ring infiltrate, but there are actually many organisms that can cause a ring infiltrate. And in the setting of a positive enterococcus culture, you would probably go ahead and treat the enterococcus before thinking of any other etiologies. But because it was worsening, we got this confocal, and it clearly shows that there's acanthamoeba here. So the patient was readmitted to the hospital, started on other oral antibiotics in the case of polymicrobial infection. PO steroids were not given because of the acanthamoeba. There's controversy and debate as to whether steroids should be given, both topical and oral, but that's beyond the scope of this discussion. And we started polyhexamethylene, PHMB, and chlorhexidine on this patient, initially starting at every hour and then dropping down to 4 times a day. Slowly, the active keratitis resolved. We tapered the PHMB and the chlorhexidine, but he was unfortunately left with extensive corneal scarring with limbal involvement. So now we have this 37-year-old man who, in one day, his life was changed. He got Stevens-Johnson syndrome, went from having 20/20 vision in both eyes to LP vision in both eyes, initially with the active keratitis and inflammation. After treatment, now does not have active disease, but is left with hand motion vision OU, can't work, social life has completely changed, and patient is notably very depressed. So now we have to think about what the surgical options for such a patient are. There's no great option. Every option here is going to have drawbacks. The first is penetrating keratoplasty. That would probably be the go-to just to see what the outcomes might be, given that other surgical interventions can still be done after a penetrating keratoplasty. But in a case such as this with severe limbal involvement, it's almost certainly going to fail. The other option is a keratoprosthesis. We use the Boston keratoprosthesis. There's other iterations around the world, and those are artificial cornea devices that can be placed in corneas that do have limbal stem cell deficiency. Another option is allogeneic limbal stem cell transplantation with immunosuppressive therapy. It would have to be allogeneic because his fellow eye is also involved, so it could not be autologous. This has other risks associated with it, including rejection of the graft and also the immunosuppressive therapy. And in this patient with a history of active colon adenocarcinoma, immunosuppressive therapy would in particular be quite a challenge. So we continued to watch him for some time before deciding what to do. We had some extensive discussions with the patient. We eventually decided to do a penetrating keratoplasty of the left eye, which was the more stable eye until he had a corneal perforation, which ended up being glued. And so it seemed the natural next step to do the PK in that eye. This is a photo of his eye after the PKP within 1 month, completely clouded over and complete failure of the graft. And you can see conjunctivalization of the cornea, neovascularization, dense opacity, really not going to see very well from this eye at all. And this is the right eye, which unfortunately developed another epithelial defect and infiltrate, which later grew Pseudomonas. Fortunately, that resolved. I'm going to go back here. So 1 month after the PK, that graft had failed. He developed a new infiltrate in the other eye. Topical medications were started and it resolved. Finally, we decided to go the route of a keratoprosthesis. Now, there's a lot of debate as to whether that would be the correct procedure to do in this eye. There's definitely a high rate of failure and severe complications that can occur in keratoprosthesis in patients with SJS or severe ocular surface and autoimmune diseases. But we were really left with very few choices. We needed to have some form of visual rehabilitation for this young man, and an allogeneic limbal stem cell transplantation, which would certainly require immunosuppression, was not something that we would be able to do.
Dr. Amal, excuse me, you are running out of time. Can you conclude your presentation, please? Come to the...
Sure. So we actually ended up doing a keratoprosthesis in this patient, and miraculously, the patient actually recovered 20/50 vision, despite having, unbelievable that one patient can have so much bad luck, but the corneal donor rim actually grew enterococcus. And so he developed enterococcus endophthalmitis after placing the K-Pro, remarkably improved with vitrectomy and tap and injective medications, and he recovered to 20/50 vision, likely with the right contact lens fitting. His vision should improve further. He does have some cicatricial changes of his eyelids, which will be a challenge going forward, and he will require lifelong care and management. Just 3 concluding points I would like to make is that this is the first case of acanthamoebic keratitis in a patient with SJS, but patients with SJS do have many risk factors for polymicrobial disease, and these patients need to be watched with a very vigilant eye with any signs of infective keratitis. Confocal microscopy can be very helpful in identifying the etiology in cases of worsening disease, and surgical decision-making is of utmost importance in these patients with severe ocular surface disease, and a very detailed discussion on the lifelong management is needed. And it's also very important to note that the fellow eye should be kept in reserve, because these eyes usually have only a few have a limited amount of time that it will be able to survive after surgical intervention, and leaving the fellow eye in reserve will extend the time that the patient will have useful vision. Thank you very much, and I appreciate your time. I wanted to just acknowledge some residents and medical students who worked with me on this case. Thank you.
Thank you, Dr. Hijra, for this wonderful presentation about a very aggressive case of Stevens-Johnson syndrome. But unfortunately, we are running out of time. We don't have any time for discussion. So I would like to thank all the panelists and the speakers, Dr. Hijra, Dr. Amal, Professor Aliou, Dr. Farhadi Harfazi. And I would like to thank the organizing committee for such a wonderful meeting, and meet you in the next conference, inshallah. Thank you all. Thank you.
Thank you, Tariq. Thank you for nice session. Congratulations.
Yes,
thank you. Thank you.
Salam, everyone.
Thank you.
Bye.
Bye-bye.